Development is changing, and our community is evolving with it.
The expansion of SID-Washington to SID-US reflects the reach of this wonderful organization.
An organization that not only brings together like-minded development professionals, but one that elevates diverse voices and fresh perspectives.
Over the past few years, this chapter has made a concerted effort to showcase voices outside of Washington, both nationally and internationally.
I'm absolutely thrilled we've finally taken our rightful place as a national forum and convening spot for inclusive international development.
We welcome this name change by SID, which allows it to better reflect that it really represents the organizations throughout the United States.
As an international development organization outside Washington, membership with SID-US provides us a platform to connect with US-based institutions and partner and to collaborate with them to solve complex global problems.
SID-US connects our San Diego-based team with people working in development around the world.
Changing the name to SID-US, I think, is important because it better reflects how international development really happens in the US today.
Our students appreciate being included in working groups and having access to the conferences and other events where people outside of Washington, D.C. can participate.
SID has been a critical partner, connecting us to other members and speakers for our annual symposium, providing valuable virtual events, and aligning with our goals for a more equitable global development sector.
Our membership provides so many opportunities for our students and faculty to stay connected to what is happening in the international development space.
As the premier international development association, SID is more than just those of us in the DMV, and renaming as SID-US is a great move to acknowledge this reality.
To us, the shift to SID-United States is a recognition that development extends beyond specific borders.
I'm proud to be part of an organization that really understands the importance of diversity and voices, because that's what will be needed to close the equity gaps in the society we live in.
Every voice across America should be in this conversation, and indeed, we need voices from every corner of the globe.
Having more voices and perspectives will make us stronger, better, more dynamic, a better organization.
Thank you to all of our members and partners. We look forward to continuing to work with you as the global town square of development, connecting people and organizations around the country and around the world with our expanded reach as SID-US.
To those who are here in person with us and to all those who are joining virtually. Sorry for the echo. And huge thanks to Deloitte for hosting today. We have wonderful space here and we're looking out over the Potomac and it's just beautiful. We're expecting about 150 in the room and another 100 or so online. And I think that's just a terrific turnout from our membership. And looking around the room, I'm seeing a lot of old friends I haven't seen in a long time, so thank you all for coming. We convened you here today to go over a bit of SID-US business and touch briefly on your membership benefits and some of our upcoming plans. We also want to provide a way for you to ask questions of me and the SID-US team and our board, many of whom are here today. So we're going to do all that, and then we're in for a real treat. We're going to have a fireside chat with USAID's Atul Gawande. And after that, I hope that most of you here in person will stay and just come across the hall for a reception that is sponsored by ACDI VOCA. So it should be a lot of fun. A couple of quick guidelines for today's meeting. We're recording it, and the recording will be available publicly. Virtual attendees, you should be able to access live translation closed captioning through your individual settings on Zoom. And if you have any issues with that, just post something in the chat and someone will help you. Also for our virtual attendees, if you have questions, post them in the Q&A box and we'll answer as many as we can today and we can follow up on others afterwards. And for people in the room, when we get to Q&A, you can raise your hand and just stand up and speak. This room is mic'd, so everything you say will be heard. Good morning. I'm going to introduce the SID-US team later in the program, but right now I'd like to introduce two of our board members who are going to tell you more about SID-US and our plans. Ann Simmons-Benton, to my right, is deputy chair of the SID-US board and also heads our membership committee. She has been involved at the board level in SID-US for many years and in many different capacities, including 2 stints as our annual conference chair. So that gives you an idea of what a glutton for punishment she is. She has more than 25 years of experience in the government, private sector, and academia, designing, managing, and implementing programs around the world. She's worked for Arizona State University, DAI, and USAID in Russia and in DC. She's a thought leader and early innovator and has pioneered business in the early post-Soviet days in Russia. Anne serves as a US delegate to the W20, an engagement group of the G20, where she provides expertise across working groups to ensure that women's issues are included in the G20 agenda. She's also principal at Deepwater Point. And she's a lawyer, which she reminds me of occasionally to keep me on my toes. Wade Warren, directly to my right, is chair of the SID-US board and also, in his day job, Chief Strategy Officer for International Development at Deloitte Consulting. Many of you also know Wade from his previous role as acting administrator of USAID. He spent 27 years at USAID in a broad range of senior management positions in the Bureaus for Policy Planning and Learning, Global Health, and Africa. He also served in USAID's missions in Zimbabwe, Chief Operating Officer of the Office of the Director of U.S. Foreign Assistance. We convinced him to chair our board by telling him it wouldn't really be a lot of work. But I think he spent most of his recent vacation on the Outer Banks on Zoom calls with me. So we are very, very grateful to both Anne and Wade for all they do for SID-US. And with that, I'm going to hand it to Wade to tell you a bit about our transition from SID Washington to SID-US and our plans for coming years.
Thanks, Catherine. Thank you to you and to the hard-working SID staff too. I always say this is small but mighty. There are only 7 staff people at SID, and we put on a huge number of events every year, and you guys work very hard, and we appreciate it. So thank you. I'm just going to talk briefly about 3 things because you're going to hear more from me later when Atul Gawande gets here. But I did want to say a little more about our transition from SID Washington to SID-US. You saw the great video, which I always love to watch. And we talked about it at our conference in May, so I won't belabor the point. But we have rebranded ourselves SID-US because we want to recognize that the international development community extends far beyond the Washington area. There are important actors and players in international development all across the country. We have been engaging with them virtually all along, and especially so since COVID. But we wanted to acknowledge it more formally by changing our name and explicitly expanding our mandate to embrace all the sort of non-traditional and new actors and players across the country. So we're very happy with the name change. It was a lot of work to get it done. We recognize, though, that just changing the name is not everything we need to do. We have to truly expand our mandate. If COVID taught us anything, it's that you can reach a lot of people virtually that you didn't always know that you could reach before. And even once the pandemic passes, whenever that might be, we intend to continue offering virtual programming so that people around the country can take part in hybrid events like this. We also plan to do in-person events in other cities around the country. So New York City, Chicago, San Francisco, Denver. We have plans to go to all of those places. So that's one thing I just wanted to mention was a little more about our name change and our expanded mandate. The second thing that I wanted to mention, which is extremely important to the SID board, is diversity, equity, inclusion, and accessibility. DEIA has been an important priority for SID for the last several years, and we're going to continue to prioritize DEIA as we move forward in the coming years. It's important to us as an organization, and we think it's important to raise DEIA issues for our community. So look for continued programming around DEIA issues. We have an extremely active DEIA committee chaired by Bobby Jefferson, and we have a lot of DEIA focused programming. So that's going to continue, and we think that's an important part of our mandate. And then lastly, I just wanted to let you know briefly that we are embarking on a strategy refresh or a strategy renewal for our organization. It's been a long time since we had a formal strategy, and we think with our new mandate and our aspirations, we need to be guided by a more formal written strategy. So we're just beginning this work. We've created a strategy committee. I invite any of you who are interested to be involved. We need lots of new thinking about how the organization can move forward in the coming years. We'll be talking more about that in our newsletter and in our upcoming events. So that's all I was going to say. Before I turn over to Ann, though, I did want to acknowledge our board. I love being the chair of this board. It's the greatest board in town. The people are fun and dedicated, and we get a lot done. So if you are on the SID board and you're in the room, if you please stand up so we can acknowledge you. I think everybody has a white tag. Thank you. Give a wave. We appreciate you. As I said, it's a wonderful board. The people who somebody's waving. Okay. The board members are all volunteers, of course. We dedicate a lot of time to making the SID a successful organization. And Catherine did lie to me about how much work it was to be the board chair, but that's okay. There's going to be a reception, as you heard at the end of this meeting. The board members have white tags on their name tags. So if you see them at the reception, please walk up to them, say hello, ask them questions, offer your suggestions for how SID can do its work better. And with that, I'm going to turn the mic over to Ann. I will sit here for a few moments, and then I'm going to go down and collect Atul.
Thank you, Wade. So, building on the enthusiasm in the room, I want to say good afternoon and thank you all for being here. As the deputy chair of the board and the chair of the membership, I'm just delighted to see so many people in person and online at what is our first annual membership meeting for the new SID-US. As you know from many things in life, what effort you put into things help you get the benefits out of it. And I'm going to walk you through how you can engage in SID-US so that you can benefit from it even more fully. And I'm going to ask you to look at how you can help us with our mandate to grow membership beyond the DC area so that we can all contribute to develop in international development. So who are we? So we have a couple slides in the room, but I'm going to also say some of these things for some of our members who may be listening as well. So we have over 300 individual members, and we have 150 plus institutional members. Members in 29 states, DC, 17 countries, and 130 cities around the world. And who are these members? For our individual members, we have students, we have retired, we have foreign service professionals, implementing partners, and it's unlimited who could be an individual member. We encourage you to bring more in. In addition, for our implementing partners, we have NGOs, contractors, small businesses, the private sector, universities, foundations, and embassies. We also have a large social media on Facebook, Twitter, and I would say our newsletter as well, which I would urge you to look at. So what about our participation? We have today attendees from 21 states and 7 countries that have joined us. And in our events so far this year, we have had attendees from over 80 countries. Our goal, as Wade told you, is to increase our membership beyond those 21 states and beyond the DC, Maryland, and Virginia area. But even more importantly than numbers, we want to increase diversity. As Wade mentioned, DEIA has been a priority for SID these past few years, and we will continue to prioritize it at all levels of the organization. We have increased our engagement with historically black colleges and universities, HBCUs, HSIs, Hispanic serving institutions, and other MSIs, minority serving institutions. We have also partnered with Gawande University to make our events more accessible. But again, as I said, we need your help in the SID expansion. So how do we engage? First of all, as Wade mentioned, we have the board. So I would encourage you to think about running for the board in the future. We do have elections, they are open, and we encourage individuals and members to apply. Here we have listed on the screen the board committees. There is the annual conference committee, which I would say is a pleasure to serve on. It is a lot of work, but you get to know your other members really well. You think about really exciting topics. I have to tell you, it's one of my favorite things I've ever done. Budget and finance, communications, and what's interesting about the communications committee is we actually have professionals from the community who are communications professionals serve on it, not just board members. So any of you who do that in your day-to-day, please reach out. We have Bobby, as we've mentioned already, for DEIA, and that's a big priority for SID-US. Strategic Planning Task Force, and Kate is in the room over there. I'm going to point her out because, as Wade said, it's really important to get different ideas. And I know she's planning a wedding and rehearsal dinner, so she may leave quickly, so look for her very quickly today. Governance, membership, as you know, programs, and the Rice Award selection. So that's one way to engage. The other ways to engage, which are for members, and you don't have to be a board member, are work groups, affinity groups, and networks. I'm going to have a slide now which will show you what the different work groups are. So what the work groups are, they convene on a regular basis with 2 co-chairs, and they are topical considerations where colleagues share best practices and innovations. They are open to the public, and they provide a space to engage on the following topics. And they are listed on the slide here. I'm going to go ahead and read them in case we want to be accessible for someone in the audience or online. Corporate role in development, democracy, rights and governance, development finance, education, environment, food security and agriculture, health and nutrition, inclusive development, infrastructure and urban development, monitoring and evaluation, peace and security, policy and learning, race, ethnicity, diversity, and youth and development. In addition, we have what are SID-US affinity groups, and these are a new thing because the world is changing. The events in Afghanistan and Ukraine have led to a way that we need to get members together to figure out how to address these challenges and crises. So currently we have 2, one on Afghanistan and one on Ukraine. Ukraine one met not too long ago with the mission director. It was a small group trying to figure out what implemented partners could do to help citizens in Ukraine. Same in Afghanistan. So they are temporary as long as the need continues. The next area is SID-US networks, and these are member only, and they serve as platforms to help different groups within the industry get together and network. So currently we have Independent Consultants Network and youth professionals. At this point, I would like to ask our in-person co-chairs to stand up and our virtual co-chairs to wave. Thank you. That's great. And for those who are in person, on the badges, there will be an extra co-chair badge so you can also, there's opportunities to intern for any of the working groups or serve as a co-chair. And one thing I would like to say is challenge you to create a new working group. If there's something on that list that you are is missing for you and you are passionate about it, offer to be a co-chair and come to Kathy. Also follow us on social media. So finally, what I'm going to ask you to do is call you to action. And so I want you to help us get the word out and help us grow. I'm going to also ask you to help us because we will send you a membership survey at the end of the year. And so by filling that out, it tells us what you like, how we're doing, what other new ideas you have. It's one way you can count on every year to give us that information, but you don't have to save your ideas to then. We really try to be very open to hearing that. And so having these kinds of events is a way to do it. So please help us to be the diverse and inclusive entity we want to be across the US that serves the broader development community. Please share your ideas and participate. Thank you.
Thank you, Anne. So now you know all the ways to engage with us, and one of the most obvious is through our events. And I want to make sure you're aware of a few that are coming up fast. They are listed on the slide. I'm not going to walk through them because our guest speaker is here. So I'm going to be really quick so you can get the most out of your time with him. I think you all know, everyone who's here gets our newsletter, et cetera, and knows about our events. And I hope we're going to see many of you tomorrow night at our USAID Mission Directors Reception. We think we might be having a USAID Program Officers Reception next week. As soon as we get confirmation, we will let you know. And you can see everything else up there. Some great events coming up over the next few weeks. That it really is a lot happening, even just in the next few weeks. You may be puzzling over who's actually going to make it all happen. I'm kind of puzzling over that too, because as Wade said, we are a tiny, tiny team of 7. And I'd like to very quickly introduce the SID-US staff before we get onto our fireside chat. So many of you know Julie Montgomery, who's sitting here in the front row. Julie's our Vice President for Membership and Partnerships, and that title does not capture everything she does. She's very engaged in our programs and really everything. Those of you who are here, please get to know Julie at the reception, and everybody online, I hope you will get to know Julie. Pebbles Diaz, who I think is downstairs working registration, is our Membership and External Affairs Manager. You have likely interacted with Pebbles, and she also puts together our newsletter, which I think Wade mentioned or Ann mentioned, and I hope that all of you get that. If you don't, please talk to us about that. Malvika, who was here a minute ago, Malvika in the back of the room, Rendezvous is, she manages our events and all of our work groups, networks, and affinity groups, so she's a busy lady. Dan Moreno, I think, is downstairs. Also, you probably saw him at registration. He manages our annual events, our conference, our career fairs, and our dinner. And then Noah Ramsey Lucas right here up front, who is our finance and operations coordinator and does a number of things. And you also hear from him when you owe us money. So then hopefully you don't interact with Noah that much. And then joining us virtually is Liz Moody, who is our Director of Finance and Operations. She oversees all of our internal systems, our website, and generally just keeps our organization running. And then we also have 3 interns, Destiny Daniel, Kalyani Mohan, and Ajwa Oforyao, and none of them could be here today, unfortunately, because 2 are in school and have class right now, and 1 is a virtual intern in Europe. But we have some great interns, and I wanted to acknowledge them. They really help us pull everything off. That's the team. So now we're supposed to have Q&A. But I would like to suggest, since we're running a little behind, that we go right to the fireside chat. Those of you who are joining us virtually, you can put your questions in the Q&A and we will work to answer them. We do want to hear your questions. Those of you who are here, we're all going to be here afterwards. I hope you'll corral us and talk to us at the reception. If for any reason you can't stay and you have a burning question, you can reach any of us on email at any time. Our information is on the website, and we are a member-driven organization. We really do listen to your ideas, your questions, your concerns. I really do encourage you to reach out. I am sorry to be cutting this off, but I know you guys are really here to hear from Atul and not from me. So with that, I'm going to ask Wade to, oh, I went too fast.
No.
Okay, I'm going to ask Wade to come back up and introduce the next speaker.
Come on out. Yep. Did you get the mic on? I do. Thank you, Catherine.
Oh, look, they have fancier bottles.
They did. This is sparkling and this is still.
Okay.
All right, well, let's make yourself comfortable. We'll get started in just a minute, but I did want to say a couple of words to introduce you to the group here. I know your biography is well known to most of us, and your accomplishments are many, more than I can do justice to really, but I wanted to point out a few of them. The first thing for you to know, of course, is that Atul was appointed by President Biden to be the Assistant Administrator for Global Health at USAID. He was confirmed by the Senate, and he took up his responsibilities in January 4th of this year. So he's been on the job 10 months. He was also on President Biden's transition team's COVID-19 advisory. Before he came to USAID, he was a practicing surgeon, and will be again, I'm sure, when your time in government is over. He was at Brigham and Women's Hospital in Boston, and he's also a professor at Harvard Medical School and at Harvard's T.H. Chan School of Public Health. In addition to being a government official and a surgeon, he is a widely known and read author. He was a staff writer for the New Yorker magazine, and he's written 4 New York Times bestselling books, Complications, Better, The Checklist Manifesto, and Being Mortal. And I will say, if you have elderly parents or you expect to be elderly yourself someday, I cannot recommend enough that you read Being Mortal. It's a very important book, I think. Atul got his bachelor's degree from Stanford University, his master of public health, and his doctor of medicine from Harvard University. He was a Rhodes Scholar. He's in the National Academy of Medicine, and he's a recipient of the MacArthur Fellowship and other things. So thank you very much for being here. We're really pleased to have you, and we're actually very grateful for your public service. Thank you.
Yeah, it's great to be here, especially with you.
Yeah. I was just want to remind you, we have about 200 people here in the room, and we have another 150 or so online. And folks online will be able to submit questions virtually. Questions online. And then the recording of the session will be placed on the SID website, so it's all on the record. I also want to let everybody in the room know Atul has a flight at 6 o'clock at a national airport. I was very nervous about this, but he assured me if I commit to ending at 5 o'clock, he can make it to the airport. And I'm a little nervous, right? So I'm going to ask questions for the first part of the session, and then for the last 20 minutes or so, we'll take questions from both the audience here in the room and the virtual audience. So begin thinking about what you want to know. So I'll start out with an easy question, Atul. You've been, as we just noted, you've been at USAID for 10 months now. How have you found it? Has anything surprised you?
First of all, incredibly energizing. I get to have about 800 people in DC, 2,500 people total spread across 100 countries in the health sector, and have the responsibility, which I find incredibly exciting, to have a job where my critical role is to try to enable global life expectancy for everybody globally, and reduce our burden of disease. I think the surprise to me, I mean, I knew I came in working on COVID as a I was basically co-chair, and I'm leading the global COVID response now. And so I knew there would be that emergency underway. When I asked people for advice, generally the thinking that they prepared me for was I'd spend about 80% of my time planning in months and delivering in years. And it has been all planning in days and delivering in days. The enormous number of emergencies has been overwhelming. We started with coming in with COVID, and constant work around that from day one. But then Russia invaded Ukraine, and the invasion of Ukraine meant a health disaster at levels that haven't remotely been covered. I mean, overnight, pharmacies lost their supply for an entire country. Russia is the source of a large volume of the pharmacy of medicines, and that disappeared. You had Europe being the other supplier, but under work conditions, their liability insurance disappeared, so they wouldn't drive trucks to deliver. And our team on the ground needed to flee Kyiv in order to get to safety themselves. But nonetheless, reprogrammed what we have there, $40 million, to enable a supply chain operation in support with the ministry that enabled, and by the way, with the help of Lloyd, that enabled standing up a system that could put 5,000 humanitarian aid organizations into a queue that was fed by the Ministry of Health, and then volunteer people who would stick deliveries like Uber in the back of their car or pickup truck and get it to the right location in the middle of a war zone. I mean, that was, so I'm spending the beginning of March in Poland, and April was an Ebola outbreak in the DRC, Marburg outbreak in Ghana the month after that. Marburg's even more deadly than Ebola. Summer was monkeypox, among other things, and then followed by the time we got that up and going in September, came the floods in Pakistan, putting a third of the country underwater, and now full expectation that polio will resurge again, and we have waterborne disease. I'm often flying because I need to get to Uganda, where we have a Ebola outbreak that is not under adequate control and now has 17 cases in Kampala that we believe are linked chains of transmission to a single case, and we have 300 contacts that the government of Uganda is tracing, but needing to get eyes on the ground, while Haiti is under a complete meltdown from the security situation that has caused a resurgent cholera outbreak there. So that's become my job to an extent I have not appreciated, and all along the way, I can do all of that work on all the emergencies, and we will have done nothing to recover the loss of life expectancy we've experienced during the last 2.5 years. It is the first global reduction in life expectancy in a century. Our development, it's development in reverse. We have lost years, in many cases, decades of ground, and only partly directly because of the virus. It's been taking fragile health systems and damaging them more severely. You had effects on health workers, you've had effects on trust in the health system, you've had economic damage that has led to reducing the budgets for the health sector, and then what budgets there are diverted to COVID. So we have some of the worst levels of routine immunization in years, resurgence of all kinds of illnesses, and increased maternal mortality, et cetera. That where I really want to be focused and have had to carve out time to make sure that we're driving our ordinary programming to get a recovery back on track.
Wow. I'm actually going to ask you a little more about pandemic response in a minute, but I wanted to ask you, and you started down that road already, if you could see your way clear from all these emergencies, what do you want to accomplish in the global health year? Like, what's your goal at the end of the Biden administration? Where would you like to take things?
Yeah, I mean, at the very beginning during my Senate testimony, I said I would have 3 objectives, and they've completely held up. Number 1 has been make COVID into an manageable endemic respiratory illness, and where the job is incomplete, and we'll see how adequate where we've gotten so far turns out to be, because I fully expect a surge in the next couple of months that will test how far we've come in the low income world. The second is to be better prepared for outbreaks and preventing them and managing them. And we actually have a substantial amount of funding for that. And so a lot of that work is about execution. We can talk about that. But the third was, I said, the need to accelerate our systems of primary care, to grow, to strengthen our systems of primary care. And that case has only gotten stronger. I didn't know then the data would indicate this loss of life expectancy. But we've had 20, 30 years of really demonstrating that you could use vertical programs, HIV, TB, AIDS, routine immunization, et cetera, that could deliver on results successfully. And there was a lot of doubt that you could do that in global public health. But we now know about how to go about that. You set targets, you have dedicated commitment from a range of actors across multiple sectors, and you track and drive results with a constant sense of innovating in your approaches that you bring to it. I think we now know enough to have confidence that we can move sectors of the systems themselves. And the critical thing is that many of those vertical programs have had to deal with the inability of some of the core frontline workforce by building around it rather than investing in it. And the reality is that we cannot strengthen the pandemic response. What is pandemic response? You have to teach folks how to recognize a fever that you should be worried about may not be malaria or may not be an ordinary cough. You have to be able to have diagnostic tools so that you can do something about it. You have to have a reporting system so when you find something awry, you can report it, and you have to have a response system that can manage quickly fielding a containment approach. And all of that is done by the same frontline workers who do delivery of babies, routine immunization, family planning, TB management, et cetera. So I think that primary care sector strengthening is critical. Another reason that is so important to me is that our demographic has changed enormously. The number one killer around the world is now no longer diseases of malnutrition like respiratory illnesses. It is cardiovascular disease, including in sub-Saharan Africa being the number one killer between heart attacks and strokes. And so being able to manage those risks across the lifespan, in that case, very high value, low cost interventions such as hypertensive medications and smoking cessation efforts are enormously life-saving. And we are on a path where we have the capability to provide 80 plus years of life expectancy and high quality of life for people who can access the capabilities we have in the system, both public health and health. We can do it at lower costs than people predict. I've written growth before I came in about Costa Rica achieving 82-year life expectancy on 1/6 the GDP per capita of the United States. When we were at 79 years and going down, we're now down to 76 years. And not terribly effective. And the core of it has been investment in your primary health sector with community health workers who can touch every home connected in the public health, private primary care clinics where higher level needs, the majority of higher level needs can be met. So that remains the focus and priority that we're attempting to build on, starting with 5 priority countries where we want to align our vertical investments, because I'm still caged that way, but have supported John and Kangasong for bringing PEPFAR dollars, David Walton with the President's Malaria Initiative, TB, maternal and child health dollars in some test countries where we bring it around some clear metrics around the status of the primary health system and where the needs need investment, so that we're creating sustainable pathways for those programs too.
Great. I was going to ask you a couple of questions about PEPFAR, and I'm still going to do that, but we're talking enough about pandemic preparedness that I wanted to go to that. When I was in the Global Health Bureau in 2014, I helped to lead the agency response on people. And I thought, erroneously, it turns out, that the US government and Congress was finally going to learn their lesson about health system strengthening and pandemic preparedness. And I was actually very confident that we had seen the light and we were going to do better. And we didn't. and COVID came, and I don't think we did better with Marburg, these other outbreaks. Are we ready? Are we learning a lesson? If we're not ready, what do we need to do to get ready?
You actually did pave the way, if you know it or not.
I don't, but I
in response to Ebola, it was a wake-up call. What you experienced was people with Ebola infections with Ebola circulating for 4 months before the first case was diagnosed and a response and an outbreak was declared. And then months more until a concerted response was actually mounted that began to bring it under control. And the result was an international epidemic spread through airplanes across borders, you name it, and more than 10,000 dead. In 2015, as that came down, you and among others initiated a series of investments in West Africa specifically that attempted to change that. And Tom Frieden created a metric called 717, which was the idea that you want to build the capacity of frontline workers to recognize disease, test appropriately, so that within 7 days that a virus circulating and presenting to health facilities, the case would be recognized, diagnosed, and an outbreak declared. 1 day after that, contact tracing would occur and a response mounted. And within 7 days, the initial response steps be completed. And the investment started in building laboratory capacity, training workers, et cetera, under about what became $30 million of investment that USAID made in West Africa. In DRC in 2018, there was the next outbreak in North Kivu. Still 4 months of circulating virus before the first case was recognized and case was reported. Faster response, and so it was not the level of international spread, but it was 2,200 deaths and spread throughout the region. However, by 2020, when they had what was now their 10th outbreak in DRC, the response time was 15 days. The ability to declare, recognize the disease and declare from the first case was within 15 days. Within a day, contact tracing occurred, and then they were able to mount isolation, the steps. And we now have vaccines, so ring vaccination started. And that was 55 deaths. In April, we did not have to field a team to come out and support. The government in DRC, as challenged as they are, the first case presented to a hospital, and within 48 hours, workers recognized that this was high risk. You know, they were malaria negative, persistent fever, person seemed really sick, and tested for it. They had the cartridge for the Gene Expert machine that they use for TB. They had the Ebola cartridge and could do the test on the spot, confirm that this person had Ebola, had the reporting system, pulled the trigger and called in the report, and there was the response team. And that chain of transmission was stopped there. That family was infected. There were 5 deaths. There was, but that was where it stopped, and it was completely contained. Now we have an Ebola outbreak right now, which indicates some of the challenges. Uganda is extreme, you know, one of our better prepared investments. You would not have thought that this would have taken off in Uganda. They had stopped Ebola every time previously at their border. But this time there was 6 weeks of circulating virus without diagnosis and recognition. Why? The growth of the private sector primary care clinics. Those have exploded, and the training levels and the systems are not in place for those primary care clinics and the regulations and all the steps that are required. And so they were not recognizing and suspicious. When they were suspicious, they didn't have the tests. And it wasn't until you had the first transfer into a public health sector clinic that had all of those in place that they could recognize that I had a malaria negative, had the suspicion for what made it harder, malaria negative, tested negative for standard Zaire Ebola, for which we have a test. Sudan virus had to be suspicious enough to send to the central lab, and to nonetheless, and they sequenced and found that they had indeed a new variant, the Sudan virus variant. So a complicated set of circumstances that now led to an outbreak of not out of control. It's not hundreds of cases a week, or thousands of cases like we're seeing in 2014. But we had 17 this past week. So in a populous city, which is not something we've experienced before.
Okay, so that, you make a compelling case about Ebola. We went disastrously wrong on COVID.
Yes, so here are the three things I think are really interesting and powerful about. I mean, A, we demonstrated that you can do it. And that's super important, and I think something that has to be understood. Second, you can have the capacity, you have to use it. So we have now increased the number of countries that have capacity. The United States, by the way, is #1 in the world in capacity to respond, but then you have to use it. And we didn't use it. And when we used it, we didn't use it efficiently and effectively when it came to our capacity. So enabling, we've had a variety of lessons to come out of that. So there is the investments required, and the president released his national security strategy last week, which includes domestic and international, and committed to the United States supporting 50 now low-income countries to close their gaps in ability to manage the appropriate steps for all of those things I talked about for prevention, detection, and response to be successful. Second, our measures were these capacity measures, and we have not really embraced that 717 metric, which Tom Frieden and his team have generated really recently. It's really in retrospect that we look now and see how that can be an important marker of success. And it can be an indicator of whether you have teams and countries that have the political will to use the capacity they have, to build the capacity and then use it effectively, and create visible indicators of failure and success that you can create pressure around and indicate that we're off track or we're on track, and that enters the public conversation. Third, we now have agreement around those metrics broadly. All of the interagency, all of the agency counterparts that I have, we're all pulling in the same direction on meeting those objectives, and we have been able to get resources like you weren't able to mobilize. So, when you were there, it was less than $50 million. The budget for global health security that I have is $700 million, and we're able to make major investments that help make a difference, and add to that a multilateral mechanism with what's been called the Financial Intermediary Fund. It's now increasingly used, called the Pandemic Fund, that has the ability of countries around the world to make donations and have not just the US foot this bill. And so now it's about $1.4 billion that's been put in. And so these are, the estimate is the need for $10 billion, but these are really substantial investments. These are going to demonstrate you have more countries meeting these goals and targets. And then if it can demonstrate success, I think we create more likelihood to see other countries step up to add their contribution. Good. You buy it?
Maybe. I like $1.4 billion. I like the billions. I'm mindful of time. I'm terrified about having this plane. So I think I'm going to ask two more questions, and then we'll go to
my answers are very long. I knew you'd never get to all of the questions.
I'm going to save the PEPFAR question for last before going to the audience. I wanted to talk to you. You talked a bit about how the disease burden of the world is changing, and non-communicable diseases are becoming more important everywhere, including in Africa, heart disease, diabetes, cancer, those sorts of things. Traditionally, USAID has not worked in those areas, and as they become more and more important to the countries where USAID works, are you getting out of sync with what countries need and want? And is there an appetite in the agency and Congress to shift programs to address those kinds of things?
I'm testing that boundary to find out. I mean, we 99% of our funding, as you know, was earmarked to and typically to specific diseases or populations. And it is putting us out of sync. I feel we're 25, 30 years behind on what's happening in public health. So It is now so much of a regional story, though. There was, we've been running the numbers on what's been the impact of the Bureau, because I'm trying to see all of our programs comprehensively. And what we really saw was, you go back to around 1990 and 40% in the African subcontinent, sub-Saharan African subcontinent, you had about 40% of total deaths were in women under age 50 or children under age 5. So, these groups who would benefit from the basic public health and primary care discoveries of the last century. And those are around prenatal care and safe childbirth and routine immunization and diarrheal illness and pneumonia being the biggest killers between age 1 and 5, and family planning, being able to space births, and there's a package that and our HIV work and our TB work, et cetera. All of the classic work that we have done has been successful, and at this point in sub-Saharan Africa, they're now 20% of total deaths, and in India and Asia, this is down to 10% of total deaths. So enormous progress, and you have countries like Zambia and Malawi that were below 50 years life expectancy that are now at 65 years life expectancy. So in the space of 25, 30 years, had a jump often of 20 years or so in life expectancy, which is just remarkable. But we have not recognized that we've recognized we still have work to do to close those gaps, and there are large numbers of folks who are missing out. There's a huge variability within countries, right? The urban populations are often doing better than the rural populations. But I think the second part of it is that we have to offer support across the lifespan. And as the demographics have changed, you have premature death and premature disability that goes unaddressed. It's women of childbearing age who don't survive, but then the ones who also do survive but are now with significant comorbidities. We have a world where, in the urban areas, you can have access to C-sections, we do too many of them, and then no access to C-sections in rural areas where you have massively high death rates for women. And you have now the female life expectancy outpacing the male life expectancy. And in low middle income countries, that's a significant pattern. We've done a lot of work in Ukraine, and women live 76 years there and under 66 years for men. And they die from cardiovascular disease, multi-drug resistant TB, alcohol-related illness. And that lifespan work, if we want to get to the other deaths, enable a world where we all achieve that 80+ year life expectancy and show the path. Basically, I do think it's possible in low and low countries. Okay, making the case. Yeah. And I think Congress, congressional colleagues are receptive to it. The attention is so drawn in by all the emergencies that's where all the bandwidth goes. But I don't think it's going to take long for us to see that we're not having the V-shaped trajectory on the recovery of survival. So, when I go to the Hill and say, we're at the worst level of routine immunization in years, that we have, that we've doubled the number of children who have no access to vaccination instead of going the other way, that we have almost a doubling in the number of measles outbreaks, polio back on the march, that we need to have these basic investments. The idea that we would increase investments again in routine immunization in some of these spaces has traction. So if we can move that into recognizing that we won't be successful, again, going sector by sector, but instead supporting the same health workers who are going to do the immunizations and do the malaria care and do the COVID vaccinations, I think we will be far more successful. And I don't expect budgets are going to get any better. So in the economic direction we're headed. So I think that investment is the most efficient way we can go about it, and that's an appealing message too.
Okay. So I have two.
I'm not cynical yet.
Not yet. That's great. I have two PEPFAR questions. I was trying to figure out a way to disguise them as one, but it's really two, so I'm going to ask them both. So the first one's about PEPFAR sustainability. So the President's Emergency Plan for AIDS Relief, you know, as a government, we spent $110 billion about that over 20 years. And it's done wonderful things, including keeping 20 million people alive through antiretroviral therapies. But it's a lifelong commitment to those people. So where does this go so that the United States' government is not on the hook in perpetuity to care for these people? So a sustainability question is the first one. Second one is, there's been, through the course of that 20 years, a lot of tension between USAID and the Centers for Disease Control and Prevention. You mentioned John Kangason, who was with CDC, and now he's the PEPFAR coordinator. How do you see that interagency dynamic playing out, and is there a way for them to work in synergy without the rivalry that we've seen? So two questions: sustainability and interagency dynamics.
Yeah, and the answer both come down to John Kangason. I mean, he is a remarkable leader and proving to be a great partner very quickly. His raison d'etre, I would say, from both talking to him and observing his career, is to enable African sovereignty over their own health. That is political sovereignty over the direction of health investments over and securing the future. And now in his PEPFAR role, thinking about how to do that on the broader scale, covering all of our regions. And he recognizes that there will come a point when the level of bipartisan support for the levels of funding that are achieved could run its course, and therefore has made sustaining PEPFAR a critical, one of his core pillars of his strategy. And we have we're very like minds in seeing that critical place is around enabling the frontline workforce to deliver more and more of the program. The program for HIV/AIDS has had to build through NGOs outside of government sectors, places and skills and expertise that are devoted to populations that are often ignored and undervalued by governments. And those are, the gay, lesbian, trans populations, sex workers, and other vulnerable populations that are at highest risk but often don't get programs designed for them, and they have demonstrated that can be done, and can be done extraordinarily well and save enormous numbers of lives. And transitioning those capacities into governments through their primary healthcare sector is key. And one of the places we aim to be able to start by doing that is by putting some of our investments together across PEPFAR, malaria, and a number of other areas. And we have the objective to do that starting in a couple of countries to begin with. So I think we're trying to pave that pathway. What I don't want to see happen is what happened with polio, where there were billions of dollars in investment towards the endpoint of achieving eradication, not a lot of investment in how to sustain it if it became a years and years long effort, and now suddenly finding with competing crises that polio doesn't have the billions in investment that they could command every year, and transitioning extraordinarily rapidly onto governments the surveillance and response capabilities that they weren't trained and equipped to do. And we've seen some of the consequences with recurrence of cases in sub-Saharan Africa and a couple of countries where vaccination rates for polio dropped, and so that people are working to remedy that. We're working to raise money to meet replenishment for polio. But I think the work to start now, while we still keep closing the gaps in HIV/AIDS control, is the right dimension to go, because it will take years of work. One example, and we can go to the questions. I'm sorry, it's also interesting. I've learned so much in this job. Vietnam, where I'll be headed in 2 weeks, is striking to me because they have successfully transitioned to the government that they are paying for all those HIV drugs we pay for. So the government has got a universal coverage program. They cover a medicines list, and they agreed to pick up the costs of the HIV drugs, which is one of the biggest items on the budget. And that ability to make that transition while we continue to do community engagement, risk communication, other components of the program, I mean, that is a roadmap for success.
Okay. Are you dodging the question about interagency?
Oh, yeah. Interagency, right. I think it's embedded, though, in the fact that we have been able to begin working. It is set up for us to be at each other's necks, yes, because country by country, you are fighting between CDC, USAID, and the other government partners over who gets how much money, and the PEPFAR coordinator makes their call, and that is set up for us to battle against one another. How to mitigate that, partly with starting at the top and trying to set a culture and tone of what we can do, but also how we can mitigate some of it.
Great, fair answer. All right, we have 20 minutes and not 1 minute more for questions from the audience and the audience online. I promised Anne, who's the deputy chair of SID, that she could have the first question, and then I already see hands up around the room. And we have some online as well. Okay, so Anne.
Well, I'll be quick, but the W20 this year, their communique to the G20 put three global health issues into the communique. I'll just pick one for now. But what about getting to the rural areas, which you mentioned? Is there a way to look at digital as a solution? And can you just talk about that a little bit?
Do you want to repeat the question? I don't know if people online would have heard it.
The room is mic'd, so they should have been able to hear.
Magic, okay. So I come in as a, oh yeah, they didn't hear it.
So I was just saying the nexus between digital and the rural areas to help women.
So I'm a tech skeptic, and despite having been at Haven, where we did a lot of tech, putting together Amazon Virtual with JP Morgan, the idea that telehealth that can be delivered for services has been enormously successful in mental health, because you can do virtually all of the assessment, management, follow-up digitally, and that has been remarkable. And we've been in USAID, that has been a space we've actually invested in. It's been important. It's played an important role in Ukraine, for example, in the post-traumatic stress management situations. And so I'm a fan there. In primary care, around these needs, it's very good for being a source of information for people, but you have to have physical connection to make it work. You have to be connected to a pharmacy network so you can deliver prescriptions. You have to be connected to a lab network and then get the results back and be able to transmit. So there has been success in many places on a small scale with telehealth programs that have offered you diagnosis based on what assessment you can do, but it's been very limited, kind of narrow urgent care, and where it can become successful, and I'm very interested in it, is have done work previously on, is where it's a kind of mobile first access system, but has to be integrated into capacity to direct people to the right facility, do real diagnosis and assessment, get physical exams. We've done it in rural areas. I shouldn't say we anymore, because I'm just not part of it, but I founded a center called Ariadne Labs, where we have, on the domestic side, enabled Medicare payment that now goes for hospital at home, and have got a strategy that is bringing it into rural areas. Currently, urban areas within 5 miles of the hospital. We've gotten as far out as 50 miles from hospitals by using paramedics, who are often the most populous workforce, are willing to be trained to do on-site management. And then when things turn south in ways they can't manage at home in a home setting, they can loop into telehealth to bring in physician evaluation and manage on site, or else put them in the ambulance and take them forward. So I think those kinds of approaches are evolving, but we're still a long way from being able to see that, to me, scale unlike the network.
Great. I'm going to take 2 questions. Kate, I saw your hand, and then I'll take one from over here in the back there. Kate.
Hi, I'm Kate Bunting. I own my own consulting firm now, but in 2014, I left USAID to go be the CEO of an organization called HelpAge, devoted to working with people over the age of 50 in development and humanitarian situations. So I love that you're thinking about it. I love some of the references. There's a whole range of care that is not available to older people in really sub-Saharan Africa. Although I would encourage you, if you're going to Vietnam, to visit some of the community health programs. So I guess my question is what progress do you see being made beyond just getting some access to blood pressure medication, that type of thing? How do you see community health workers and the ability to strengthen the health system to be more accessible to people over 50?
All right. Thanks, Kate. I'll take one here in the back down.
And I just wanted to ask, where does the city of responding and being part of that, besides the malaria issue?
Great. So I have it in. Yeah. So so the article I wrote about Costa Rica was a chance to dive deep into a country that had in the 1980s, those programs became more successful. They eliminated malaria in Costa Rica. They achieved over 90% routine immunization. They, diarrheal illness no longer was the biggest killer of kids under age 5, and made progress in those ways. Women were now surviving childbirth and not, having their peak risk of life during their middle years. And by the 1990s, they actually had not only improved to become the best survival in Latin America, they had matched US survival. And as they came across people who now were the span of the lifespan, diabetes was on the rise, cardiovascular disease was on the rise, and they built up the capability to manage those basic needs for chronic lung illness, chronic heart disease, and being able to reduce and address them. By the year into the 2000s, they began to surpass US life expectancy. They're now 82, as I mentioned. And they got there. They actually have more geriatricians per capita than we do in the United States. They have built in the, when you have public, one of the interesting pathways, I think, is that they combined the equivalent of their CDC and their Medicare program, so that you had public health officials guiding where the strategy and investments were going for what the community health workers focused on and the primary health clinics focused on, and drove data-driven epidemiology for what you did. So They were managing diabetes with elderly populations. They were addressing keeping people safe in homes. And the consequence of that was making it so you were getting past what I see as a kind of 65, 70-year life expectancy cap on what you can do with that basic infrastructure and enabling capacity. They don't do great at specialty care. They have more gaps they can close. There's often waiting lists, but it shows what you're capable of when you have a strong community-based primary health system. And I think we can actually learn a lot from that here and use, expect that scaffolding to be how we build in countries around the world, I'd say, for that ladder. On climate, there's so many dimensions in which climate is coming in now. Climate catastrophes, I think, are one of the biggest reasons, along with conflict, that it's hard for us to have a V-shaped recovery in life expectancy. Pakistan, to me, was the apocalyptic story of climate with, almost a landlocked country being 1/3 underwater. Samantha Power told me when she came back that she'd taken a helicopter out to survey the floods 2 weeks after the floods. And this was just a rainstorm that didn't stop, right? A biblical kind of story. And she went 4 hours out on a helicopter and had nothing but water on the horizon the entire way. The only places you could see people come up with are roads where there were just lines of people along the roads afraid to leave their land. And that, Mozambique has been hit by a succession of cyclones that have disrupted the health system and health services. And that's simply on the rise. And so a big part of our work is now climate adaptation, right? How do we adapt to the climate, whether it's the demographics of how disease patterns have changed, whether it's indications that, these countries that are experiencing floods. There's a recent paper in JAMA from September showing that rates of HIV rise as you get particularly young women, young girls unable to go to schools, trapped in homes in abusive situations, and a variety of other causes. So there is a substantial amount of work that's on the adaptation side. On the mitigation side, it's now become part of our task as well. And we have a climate coordinator that has now created the USA's first climate strategy. And that has become a big part of something we are all contributing to, including, on the basic levels of our healthcare facilities should be vehicles to enable better sources of energy in using solar and more resilient forms of power, to reducing our waste and footprint. Healthcare is disproportionately a source of waste and doesn't take into account the effects we have on the environment and in the communities where we're working. So there's a wide agenda where we can play a very significant role, even if we're not the lead on making those things happen.
Great, thank you. So I understand Liz has
several questions.
We'll take two. Liz, are you going to speak out of the ceiling?
Out of the nether world.
Yes, we have a few questions from folks online.
Yes.
So first question is from Michaela Nesson of Palladium.
We're
She
not
asks,
here. I see something, so that means she's on mute. The captioning is working.
You know what?
You want me to read that?
Yeah.
I have.
Yeah, okay, thank you.
Okay,
Take
what
two good
role,
ones.
so it is from Michael Rodriguez from Action Against Hunger. What role does USAID see AI playing in identifying likely future outbreak locations? Question one. Another question from Oluwole, an MA student at Clark University. Please, what is USAID doing to ensure vaccine independence production in Africa and poor nations?
Great question. Both of them great questions. So our Center for Innovation and Impact actually just put out a report on AI in global health development. And there have been a number of areas where AI tools have suggested there might be potential, such as outbreak prediction. Not yet convincing to us that the tools have reached ability to be prime time yet to say, okay, we're going to actually surge resources here because the AI tool says test or look for et cetera here. But there, and so it basically mapped out which of the areas seem most promising, outbreaks potentially being one, and which ones seem like they are still far from having potential. I'll tell you the one that's actually now live and showing signs of being quite successful, and that is low-cost portable X-ray read by an AI system for TB patients. And so we were actually deploying that now in India and a couple other locations where they are diagnostics where you ordinarily need a radiologist. You don't need a radiologist now in order to have a chest. So, someone who has a cough, you get a chest X-ray. The chest X-ray can indicate whether it has a high risk of being TB or not, and then prompt the molecular TB test and reduce the cycle time for identifying people at risk of TB. So I'd say we're in the nascent days of how AI will be transformative, but I think that's an indication of the kind of spaces where they are. And you've actually turned it from, wow, this could be really powerful, to it's been engineered to plug into a system and algorithm where you actually make a difference in what you're doing on a day-to-day basis.
Vaccine independence.
Oh yeah, that's such that question. So this is a hot topic. They're at the largest level. I would say we're having an interesting pivot on globalization, which is recognizing that local production actually matters. And Rana Faroohar, not paid or anything like that, but has the economist from the Financial Times, has a book out called Homecoming that is I'm partway through now, which is describing how in the pandemic, the fact that supply chains were not able to be just in time, the fact that you were deeply dependent on very low sources of labor, which don't actually benefit in significant ways, and that where the pendulum is swinging back towards needing to have local production for security reasons and diversified production for resilience of economics, et cetera. So African manufacturing has now gotten a significant amount of investment for vaccine manufacturing because of the pandemic, but unfortunately been in a situation where you're building places that were designed to do COVID vaccines, and now we have a flood of COVID vaccines, and making sure that we have a viable market and approach on it is critical. And I think the elements that are essential that we're carrying out is we at USAID are driving an analysis for organizations like the African Vaccine Alliance, ABAT, and Pavan from the African Union, for Gavi, with Gavi and with Pavan, with Gates Foundation, with the Clinton Health Access Initiative, all of us working together to cost out, first of all, launching how much more does it cost per vaccine? Second, where will there be potential markets? We have shortages of, we have supply chains that are too small for vaccines like cholera vaccines, where we have a global shortage of cholera vaccines. And opportunities where routine vaccines like that can become the base of vaccine manufacturing regionally. So there is a viable construct and support payment for those. And then the ability to have investments that allow for capacity to pivot in the case of pandemics to Ebola vaccine production or vaccine production for coronavirus or other critical needs. And so just as our vaccine manufacturing capacity could pivot, the same thing is there abroad. And in India and Brazil, they have a manufacturing base that's enabled that capacity to happen. We clearly have to do that in Africa, but based on partnership with regional associations like African Union, African CDC, major buyers like Gavi, to arrive in that same space. And, we talked about PEPFAR, but that's a major goal also for John and Kingsong to be able to have local manufacturing of HIV drugs and of rapid diagnostic test capabilities as well.
Great. All right, as I have mentioned repeatedly, I'm committed to getting you to the airport, so we're gonna stop there. But I just want to say, Atul, your intellect and your energy, you could be applying yourself and have to many other endeavors, and the fact that you are working for the American people in the U.S. government is something that we all just appreciate so much. So thank you for being here. And I have a couple of announcements, so thank you very much. All right, I'm going to be very quick because we have a reception coming up. I just want to offer actually a few words of thanks. First, to my firm, Deloitte, for hosting this meeting today. It takes a lot more work than you might realize to have something run this smoothly, and we had a lot of people helping us. So I'm looking at you, Anna Maria, Nick, and Jainaba. I don't know if folks are even here in the room, but we appreciate everything you've done. We also had a very good turnout of Deloitte partners this afternoon, and I especially wanted to acknowledge Kathleen Odell, who's the head of International Development Practice here at Deloitte. So thank you for being here. If you see them at the reception. Which brings me to the reception. Is Sylvia here?
No, Sylvia couldn't make it. She's got another.
Okay, that's terrible. Well, we are very grateful to ACDI Boca for hosting the reception. Sylvia is on board and one of the great board members. So please join me in thanking them for hosting. And to the virtual audience, thank you for joining us and for your questions. Those are great questions that they provided. We appreciate your participation. This concludes the virtual portion of the meeting. But for those of you here in the room, we do have a reception. It is
Sounds good. Yeah.